Okay, very well. Ok, buenas tardes a todos. Sean ustedes bienvenidos. Estamos transmitiendo un webinario de la Asociación Mexicana de Ultrasonografía, Crítica y Urgencias. Sean ustedes bienvenidos. Estamos muy contentos. En esta ocasión hemos preparado un webinario muy especial para toda nuestra comunidad de anestesiólogos que nos hacen el favor de vernos en muchísimos lugares. Aprovecho en este momento para saludar a nuestros amigos de toda Latinoamérica, especialmente a nuestros amigos peruanos, a nuestros amigos de Bolivia, que siempre nos hacen favor de vernos, de seguirnos en todas nuestras plataformas, a todos aquellos que han tomado cursos con nosotros, les mandamos un afectuoso abrazo, a nuestros amigos en Colombia, en Argentina, en Uruguay, en Brasil, allá en Centroamérica también tenemos muchos seguidores, les agradecemos que estén con nosotros y pues bueno, como ustedes saben, estamos en la temporada 3 de estos webinarios y actividades que tenemos programados para todos ustedes. Hemos tenido ya diferentes conferencias en línea con una gran variedad de médicos muy, de alguna manera influyentes en todo el mundo en el tema de la ultrasonografía crítica y además también en otro tipo de temas muy interesantes. Así es que sean ustedes bienvenidos. En esta ocasión nos acompaña el doctor Stephen Haskins desde Nueva York, quien es anestesiólogo y ha publicado varios artículos interesantes sobre el uso del ultrasonido, así como de la enseñanza del mismo para los anestesiólogos. Pero antes de iniciar con nuestro webinario el día de hoy, les voy a presentar a nuestro profesor invitado de nuestra asociación, de nuestro grupo, al doctor Rodrigo Álvarez, quien se encuentra en la ciudad de Puebla. Él es director médico del Hospital Betania Christus Muguerza en la ciudad de Puebla y él es parte de nuestro grupo, es parte de nuestros profesores. De hecho, el doctor Rodrigo actualmente se encuentra encargado del capítulo de la ultrasonografía Point of Care para los eventos del Colegio Mexicano de Medicina Crítica y es pues prácticamente desde la fundación de nuestro grupo y desde que estas actividades se iniciaron en nuestro país, él ha sido parte de los maestros que han enseñado el ultrasonido Point of Care, tanto a anestesiólogos como a intensivistas. El doctor Rodrigo Álvarez es también anestesiólogo y es por eso que lo hemos invitado, además de que él también tiene un programa de ultrasonografía Point of Care, está capacitando a personal paramédico desde hace muchos años. Él quizás sea el único que está llevando este programa a nivel nacional en la ciudad de Puebla. Todos sus paramédicos actualmente están capacitados en el uso del ultrasonido Point of Care en el ambiente prehospitalario. Así que, Rodrigo, bienvenido también a ti. No sé si quieras, te damos la bienvenida, no sé si quieras saludar a nuestro invitado y a nuestra audiencia. Rodrigo, ¿cómo estás?
¿Qué tal? Buenas tardes, bienvenidos a todos y es un gusto estar aquí acompañándolos y aprovechar estas sesiones donde pues cada día nos extendemos más, ya la parte de medicina crítica, la parte de anestesiología prehospital y hoy pues meternos ya más de lleno a la parte de anestesia donde estábamos un poco abandonados acá en el país y ya es momento de empezar a trabajar esta parte del point of care en la medicina perioperatoria. Pues,
Así es, Rodrigo. Así
bienvenidos
es.
pues estamos aquí pendientes de la plática.
Exactamente. Y pues bueno, vamos entonces a pasar a presentarles a nuestro invitado, el doctor Stephen Haskins desde Nueva York. Él es anestesiólogo en el Hospital para la Cirugía Especial allá en Nueva York y como les comentaba, él ha estado involucrado en diferentes actividades de enseñanza a través de sus publicaciones a los anestesiólogos. Como ustedes van a poder notar, realmente el uso de ultrasonografía Point of Care para anestesiólogos es cada vez más importante y más útil que ellos utilicen esta fabulosa herramienta en estos escenarios. Así que démosle la bienvenida al doctor Stephen Haskins. Dr. Stephen, thank you so much for accepting our invitation. We are very happy and I'm very honored for having you. Thank you so much, Stephen. And let's get started with your conference. Thank you so much.
Okay, well, thank you so much for having me. It's an honor to be amongst some of the many very impressive people that have presented with this webinar. So I'm Stephen Haskins. I'm an anesthesiologist, as they mentioned, from the Hospital for Special Surgery. And it's my honor and a thrill to be able to talk to you about a topic that I've been incredibly passionate about for, I'd say, about 7 years now, which is the emerging role of point-of-care ultrasound as an incredibly powerful tool for the anesthesiologist in the perioperative setting. Now, point of care ultrasound in the field of anesthesia is a relatively new topic. And so usually when I poll audiences of how many people have heard of point of care and anesthesia, not so many hands go up, although that has been changing as of late. And so, as I mentioned, it's a relatively new topic. And what I've seen over the course of the last several years is that it's gone from what I would describe as an emerging topic, something that people are just starting to think about ways in which they can incorporate this into their practice and start using it clinically, to a hot topic where it's on the cover of some of our major anesthesia journals in the United States. Lots of sort of high profile articles were being published. And as of late, what I've found is it started to sort of seep its way, to work its way into the very foundation of what it means to be an anesthesiologist and the way that you practice anesthesia going forward. And I think the next generation will be using this as their way of evaluating patients at the bedside. Now, I know that this is a society that teaches a lot of point of care ultrasound, but I'm going to very quickly define it. And essentially what it is the use of ultrasound at the bedside, so at the point of care. And what we're trying to encourage anesthesiologists to do now is, instead of just using ultrasound for bedside assessment for procedures like vascular access, central lines, and peripheral nerve blocks, but to now use ultrasound in a diagnostic fashion to be able to evaluate patients at the bedside. And often it's patients who are in acute or critical type states. So it's that patient who's showing signs of hemodynamic instability, undifferentiated shock, in respiratory distress, or you can use it to answer any sort of clinical question at the bedside that would otherwise require timely or costly imaging modalities. And so the way that we often talk about point of care ultrasound is we describe it as the 21st century version of a stethoscope. Instead of now only being able to listen to our patients, we can actually look inside of them and be able to evaluate them for obvious and potentially life-threatening pathology. Now, anesthesiologists, when we think of point of care ultrasound, often gravitate to transthoracic echocardiography or focused cardiac ultrasound. And I think that's because of our familiarity with echo and the cardiac ORs. So what I want to talk about are some other point of care ultrasound skills that are just as practical in the perioperative setting. And I think in addition to being a lot easier to learn, can be just as impactful in terms of managing patients in the perioperative setting as a transthoracic echo or a focused cardiac ultrasound exam. So I'm actually going to talk mainly about lung ultrasound, gastric ultrasound, and also the role of the FAST exam in the perioperative setting. So I don't have anything to disclose, and I work at an orthopedic hospital, and so I often feel like I need to have some form of sports reference with all my lectures. So I want to talk to you all about the ultimate competition. Now, I don't mean the Gold Cup final between Mexico and the US, but instead I want to talk about the future of the physical exam. And so on the left side of the screen, we have a handheld ultrasound device, and it's going to go head to head with our tried and our true stethoscope. And so this was a study that was published in the American Journal of Cardiology in 2005. So if you think about the technology that they had 14 years ago, and what they did was they took 2 medical students, they gave them 18 hours of training in transthoracic echo, and they gave them a handheld ultrasound machine, and they went head to head with 5 board-certified cardiologists that could only use their stethoscope in their bedside exam. They were asked to evaluate patients with known cardiac pathology, and their diagnosis was ultimately checked by standard echocardiogram. And what they found was, of the almost 240 abnormal findings that were seen on standard echocardiogram, the medical students got the correct diagnosis 75% of the time, while the cardiologists only got it about 50% of the time. They were more specific in terms of their diagnosis, and they were more sensitive when it came to non-valvular pathology. Now, what am I saying here? I hope you don't think that I'm suggesting that a medical student with an ultrasound machine is somehow going to do a better job of managing patients than a board-certified cardiologist, because obviously that is not true. But what this demonstrates is something that we have seen time and time again over the course of human history, and I would argue particularly in medicine, which is that technology has the ability to very rapidly bridge the education and the experience gap. And so when we take this technology and we now put that in the hands of skilled practitioners, we have the ability to dramatically improve patient care. Now, this was an editorial that was published in the New England Journal of Medicine titled Point of Care Ultrasound in Medical Education. Stop listening here is we have some Harvard medical students that are using a handheld ultrasound device as a means to augment their physical exam on the standardized patient. And I really like this quote because I think it's the reason why I'm motivated as an academic clinician to teach and to train as many people as possible, which is that a generation of physicians will need to be trained to view this technology as an extension of their senses, just as many generations have viewed the stethoscope. And that development will require the medical education community to embrace and incorporate the technology throughout the curriculum. And so that's what we've been doing at our institution, at the Hospital for Special Surgery. We have been training our fellows and our residents in point of care ultrasound. And if you work at an academic institution, I believe that the onus really is on us to make sure that future generations of anesthesiologists know how to use this tool to guide care and improve patient outcomes. But even if you work in a private practice type setting, I want you to know that the reality is that the next generation is going to learn this, they're going to start using it, and so if you don't get ahead of things, you're going to very quickly be left behind. I was very fortunate to be one of the co-authors in this call to action that was put forth by the Society of Cardiovascular Anesthesiologists in the US. It was published in ANA back in 2016. And it was a call to action for perioperative ultrasound training in anesthesiology residency. And they gave very specific recommendations, which is that during anesthesiology residency, perioperative ultrasound training should be continuous and structured. And because of the importance of ultrasound to the evolution of anesthesiology as a specialty, it would be prudent to develop and implement a fundamentals of perioperative ultrasound education and training to be universally adopted in accredited anesthesiology training programs. So the good news is this call went out in 2016 and it has since been heard. And so for people undergoing anesthesia training in the US, the American Board of Anesthesiologists, the primary certification as of January 2019. Under the advanced topics, you can see things like echocardiography, and down there at the bottom, we see point of care ultrasound, including lung, IVC, bladder, and gastric. These are the most recent recommendations and requirements from the Graduate Medical Education Society for Anesthesiology, and this is what they recommend. So not only do they recommend use of ultrasound for procedures like vascular access and ultrasound-guided regional anesthesia, but now you start to see incorporation of things like transthoracic echo, obtaining standard views of the heart, looking at cardiac function, being able to identify gross pathology, and also looking at the lung in terms of pneumothorax and pleural effusions. And so, as I said, now this is starting to seep its way into the very foundation of what it means to be an anesthesiologist, and going forward, the next generation is going to know how to use this to help improve patient care. Now, when it comes to teaching and learning a point of care ultrasound, there are a lot of different ways to go about it. As I mentioned, this was a hot topic, and so this is the cover of Anesthesiology from September 2015. And it's all about teaching and learning point of care diagnostic ultrasound. The article that was highlighted in this issue was by Dave Ramsing and his colleagues at UC Irvine. He's now at Loma Linda. It was all about the impact of providing their anesthesiology residents with point of care ultrasound training. And so what they did was they developed this comprehensive perioperative ultrasound exam called Foresight. Now, Foresight stands for Focused Perioperative Risk Evaluation Sonography Involving Gastroabdominal Hemodynamics and Transthoracic Ultrasound, which is a little bit of a mouthful. But what you can see with this image is that this is a true head-to-toe, bedside, ultrasound-guided physical exam. You can use things like optic nerve sheath diameter to assess the ICP. You're using things like airway ultrasound to look at endotracheal tube placement. Obviously, you're looking at the lungs for things like pneumothorax effusions, looking at the heart, and looking at the abdomen, not just for things like free fluid, but actually to assess the gastric contents and assess a patient's MPO status. And so what they did was they took their CA 1 through 3 residents, and and they enrolled them in this comprehensive ultrasound exam. It was a 2-year curriculum, and it involved things like didactics, followed by simulation, followed by hands-on training, and ultimately clinical correlation as well. And I truly do believe that this is the gold standard. This is the way that we should be training the next generation of anesthesiologists. But with that said, it has been shown time and time again that limited training can actually help address simple yet clinically important questions using point-of-care ultrasound. And that is particularly the case once we move away from things like echocardiography that require a lot more training and expertise, and we look at things like lung ultrasound, gastric ultrasound, and the FAST exam. And so that's what I'm going to discuss now going forward. And so the first topic I'm going to discuss is lung ultrasound. And I'm going to give you a clinical scenario, and this is a real case of mine. I was on call, and I was asked to evaluate a patient who developed respiratory distress in our recovery room. And so we have an 82-year-old male. He's status post left total shoulder replacement, and he's got, a pretty significant medical history, including coronary artery disease with a history of congestive heart failure, mild COPD. His anesthetic was a general anesthetic with a supraclavicular block, and now he's 3 hours post-op and he's developed some respiratory distress. And so when we see this patient, the differential diagnosis for them is actually quite broad. If you think about it, right, there's systemic disease. So this could be a COPD exacerbation or a congestive heart failure exacerbation. This could be a complication from our block. So we did a supraclavicular block, but there's still a 30 to 50% chance that we might have knocked out the phrenic nerve, and now he's having issues breathing because of diaphragmatic dysfunction. Or that needle was right by the lung, and it's possible that you could have violated the pleura, and now the patient has an expanding pneumothorax. Our general anesthetic was performed with an LMA, and so it's possible that he may have aspirated during the case and now is presenting with an aspiration pneumonia. So as I said, this differential is quite broad, but the good news is lung ultrasound can actually help you rule out or potentially diagnose all those concerns within the differential diagnosis at the bedside. Now, why is this important to us? Well, in the perioperative setting, we routinely use ultrasound, and we use it for things like peripheral nerve blocks and for central lines. And I think a lot of us have started using ultrasound because we think that it's going to improve the safety with these procedures. But the reality is that we can't always view our needle tip perfectly all the time. And so this is an example of a paravertebral block where you're actually purposely putting the needle directly next to the pleura while you're performing this block. So say you're performing this block with a resident, a fellow, or by yourself, you aspirate and a significant amount of air comes back. So now you're concerned that you may have actually violated the pleura and the patient is at risk for a pneumothorax. So what are you going to do? So if you're in the operating room and the patient seems to be doing okay, maybe you'll go forward with the case and order a chest x-ray afterwards. If you're in a holding area and perhaps they develop some respiratory distress, you might order a stat chest x-ray. But the reality is that small pneumothoraces are missed anywhere from 30 to 80% of the time in patients if you're performing a supine chest x-ray. And so this was a meta-analysis. It was published by Ding in Chest in 2011. They took a look at 20 different studies comparing lung ultrasound to chest x-ray using CT scan as a gold standard to diagnose a pneumothorax. And what they found was that the sensitivity and specificity for something like chest x-ray, 52, 99%, while for lung ultrasound, it was 88 and 100%. And so you actually have the better imaging modality with you in the room when you're performing that nerve block or placing that central line to evaluate for pneumothorax than if you were to order a chest x-ray. Now, why else is this important for us? Well, we as anesthesiologists really are perioperative physicians. We're often on the front lines when it comes to evaluating patients preoperatively, intraoperatively, and postoperatively who develop respiratory distress. And so this was a study that was published in Chest in 2008 by Dr. Lichtenstein. And what they did was they enrolled 260 patients who were admitted to the ICU. They performed lung ultrasound on them to come up with a diagnosis. And that diagnosis was ultimately checked with what their confirmed diagnosis was for that admission. And what they found was that for something like pulmonary edema and CHF, the sensitivity and specificity for lung ultrasound was as high as 97 and 95%. And it was similarly high for asthma, COPD, pulmonary embolism with a known DVT, and pneumonia. And so again, this is a way for us in the perioperative setting to help guide management, assess patients at the bedside, and ultimately improve patient care. I'm going to go through some of the ways to evaluate a patient for a pneumothorax, and primarily go through how to rule out a pneumothorax and also ways to diagnose it. And so the way that we can rule out a pneumothorax is utilizing some of these relatively straightforward ultrasound tools when we're scanning the lung. And so the first thing that we're going to look for is something called lung sliding. Now this is lung sliding over here, and it's a shimmery, shiny, sort of back and forth type movement that we see on the pleural line. Now what this represents is in a patient who is breathing, they have a static parietal pleura that's going to be adherent to the chest wall, and then they have dynamic visceral pleura that's adherent to the lung. And as that patient breathes in and out, these two pleural layers are sliding up against each other. Now, lung pulse is similar to lung sliding in that we're seeing these two pleural layers interact with each other. But instead, this is often seen in a patient who's apneic, who's not breathing. And so instead of this back and forth type movement, we see a pulsatile type movement, a vertical pulsatile type movement that represents the heart beating and pumping blood into the pulmonary vasculature and physically moving the heart. Another thing that we can use is M mode to visualize something called the seashore sign. M mode is very sensitive to movement, and so when the lung is moving, we're going to see this sort of sandy, homogeneous, granular type of appearance down here, and the chest wall is minimal movement, so these look like ocean waves crashing onto a sandy beach. And then B lines are another tool for us to rule out a pneumothorax. And B lines represent essentially a little bit of interstitial fluid, or a lot, depending on the patient's circumstances. But by seeing a B line, essentially what's happening is we're visualizing the lung tissue directly underneath the visceral pleura. And that allows us to see these B lines, these, as they've been described, rocket or comet or laser artifacts that emerge from that tissue directly underneath the visceral pleura and go all the way down to the edge of the screen. And so if we see any of these things, we can rule out a pneumothorax. So why is that the case? Well, the reality is that there's a very simple principle in ultrasound, which is that air and ultrasound just don't mix. And so when ultrasound encounters air, there's rapid attenuation, which means that those ultrasound beams are essentially unable to see anything deep to the air. So if you've ever performed a peripheral nerve block or placed a central line where you get just the smallest little air bubble in the field, all of a sudden you can't see anything deep to it. And so that same principle applies when it comes to lung ultrasound. And so if we get even the smallest amount of air between the parietal and the visceral pleura, then all of a sudden the ultrasound beams are no longer able to visualize the visceral pleura or any of that, tissue directly underneath it. And so when we have air, we have a pneumothorax, then lung sliding, lung pulse, and B lines will disappear. And so that principle, this rapid attenuation is why it's so incredibly sensitive for assessing a pneumothorax. Now, when it comes to diagnosing a pneumothorax, what we're going to look for is something called lung point. And lung point is the edge of our pneumothorax. And if you take a look at this chest X-ray or the CT scan, you can probably use your imagination here that this is where the two pleural layers, the visceral and the parietal pleura, are connecting again. A lot easier to see in this CT scan here. But that's something we can actually see using lung ultrasound. And so when a patient has a pneumothorax, usually the presence of lung sliding, lung pulse, and B lines and so on disappear where the pneumothorax is. And so you're going to scan laterally until you start to see on the screen the presence of lung sliding and the absence of lung sliding within the same lung window. And so if you see that, then that represents a lung point. So what we see here, presence of lung sliding, absence of lung sliding, this sort of highlights that. And so this would be considered a lung point, and that's about 100% diagnostic for a pneumothorax. Now, M mode, before, what we saw was something called the seashore sign. Now, when we have lack of movement within the lung tissue, then we end up seeing these ocean waves go all the way down to the edge of the screen. And so it takes on the appearances similar to the stratospheres of our atmosphere, or it looks like a barcode on the back of a book. So these are all ways to help you potentially diagnose a pneumothorax. As I said, lung point is about 100% diagnostic. Now, B lines, as I mentioned earlier, do represent evidence of interstitial fluid. Now, it's normal for our lungs to have a little bit of fluid in them. And therefore, it's normal to have up to 3 B lines depending on your age. But in a patient who has normal, fully aerated lungs, we really shouldn't see any B lines. So as you move into the direction of a mild or a moderate interstitial process, you're going to see a lot more of these B lines. And this total whiteout that we see in this image, that represents someone with severe interstitial edema or alveolar edema. That's that ARDS or acute lung injury patient. And then here, what we see is a consolidation. So our lung is atelectatic, it's collapsed, and it starts to look like a solid organ. Now, I wanted to highlight this slide just because what it does is it demonstrates that if you put the probe on the patient's chest, let's say in West Zone 1, the apex of the lung where you expect that lung to be fully aerated, and you see total whiteout, a predominance of B lines everywhere, and you can automatically narrow down your differential diagnosis to something like an acute cardiogenic process or something like acute lung injury or ARDS. So when it comes to evaluating a patient for a pneumothorax, ideally, when possible, positioning is important. You want to lay them all the way flat. Now, that may not be possible in all patients who are in respiratory distress, in which case lay them as flat as possible. But you want air to rise to the anterior portion of the thoracic cavity. It's a lot easier to scan between the second and fourth intercostal space than it is to try to scan at the apex of the lung or scanning above and below the clavicle. And so if you can lay them flat and you can look for lung sliding everywhere you expect air to be in the thoracic cavity, and you see lung sliding everywhere, then there's no pneumothorax. It's really that simple. Now, if you don't see lung sliding, then there might be a pneumothorax, in which case you now have multiple other tools to help you evaluate. You have B lines. If you see B lines where you're scanning, there's no pneumothorax. Lung pulse, if that's present, no pneumothorax. Seashore sign using M mode, again, these all take about 30 seconds to perform, are very easy to visualize, and can help you confidently rule out a pneumothorax in a patient. But if you don't see these things, that's where you're going to be concerned, and you're going to look for your lung point. And if you see a lung point, then you've now diagnosed a pneumothorax. And when it comes to resources that are available, there are many out there for lung ultrasound. This is one of many, but this is an article that Jan Bublik, who's now at Stanford, Chris Wu, who's at HSS with me, and we have a series in regional anesthesia and pain medicine on point-of-care ultrasound for the regional anesthesiologists and acute pain specialists. I usually like to do this, which is cross out the regional and pain specialists, because it really is for the anesthesiologist in general. And these review articles are educational reviews. So they tell you how to perform the exams, how to interpret them, and how to use that to guide management. So let's come back to our clinical scenario. And so what I did was I asked our physician assistant to grab an ultrasound machine and so we could assess this patient. And I laid this gentleman as far back as possible. He couldn't lie totally flat because he was in respiratory distress. But I laid him back as far as I could. I scanned his chest wall anteriorly, bilaterally, and this is what I saw. So I saw lung sliding. I also saw a significant amount of B lines. And when I went down to take a look at his left side, I could see that his diaphragm was clearly moving. So we hadn't knocked out his phrenic nerve, and there was a small pleural effusion on his left side. And so this allowed me to confirm that this was an interstitial process. And given his history of CHF in the past, this was a low EVL case, maybe 75 mLs. He'd received 2 liters of fluid since he came into the hospital. And so he just was fluid overloaded. We treated him with Lasix, gave him a nebulizer, and he did much better. And so this allowed me at the bedside in a very short period of time to know exactly what to do with this patient instead of ordering a chest x-ray, waiting on that, and all the while guessing. So I'm going to move on to the next point of care ultrasound skill that I'm going to discuss, which is gastric ultrasound. Now, gastric ultrasound, I like to describe it as sort of the new kid on the block when it comes to point of care. It's one of the newer skills out there, but for us as anesthesiologists, I think it's a game changer to be able to have this tool available for us, because we're probably one of the only people's stomach in the perioperative setting. And so gastric ultrasound, I'm going to give you a clinical scenario, again, another case of mine. So we have a pretty healthy 55-year-old female, no allergies. She's scheduled for an elective shoulder arthroscopy, and she's the next case in my room. So the nurse calls and she says, well, she admitted to having a little bit of milk with her coffee this morning. And so the question is, do you postpone this case or do you move forward? Now, many people would say 6 to 8 hours, that's it. Those are the guidelines, and I'm sticking to them. While alternatively, some people may argue, well, the British say it's okay to have a little bit of milk in your tea in the morning. This is no big deal. But many people, I think, when they see this type of scenario, are unsure what to do and are not clear about what's the right thing for that patient and that clinical scenario. And so that's why it's helpful to have a tool at the bedside that can help you answer those questions when you do encounter them. So why is gastric ultrasound important? Well, despite us having clear NPO guidelines, NPO status is frequently unclear, and aspiration of gastric contents continues to be a major cause of morbidity and mortality for us in anesthesia. And so this was published in the British Journal back in 2011, and it was an audit of all the anesthetics. And they took a look specifically at major airway complications that result in things like death and brain damage. And so the good news is, out of almost 3 million anesthetics, only 16 patients died from a major airway complication. The bad news is that 8 of those, so 50% of them, it was due to aspiration of gastric contents. And so this is still a major cause of morbidity and mortality for us in the anesthetic setting. Now, what are the indications for performing a gastric ultrasound? It is not designed to be performed on every patient. This is not meant to replace NPO guidelines, but it's to help us guide management in that gray area that we often encounter in anesthesia, where you may have a patient who's fasted for 12 hours, but they have systemic disease like diabetic gastroparesis, end-stage renal or liver disease, critical illness, or a neuromuscular disorder that you're still concerned they may have a full stomach. There are patients where there are issues with confirming their NPO status due to language barriers, altered mental status, they're demented, they're delirious, they're recent trauma and unconscious, or that inconsistent history. Oh, actually, no, I didn't really have any milk, or yeah, but it was actually 5 or 6 hours ago instead of 2 to 3. And then finally, there are those special patient populations that we're always concerned about: the severely obese, the pediatric patient who may not appreciate how eating 6 Oreos on the day of surgery can be a problem, or the obstetric patient. So when it comes to performing gastric ultrasound, the anatomy is relatively straightforward. You're going to place an abdominal probe in an adult in the epigastric area, and the first thing you're going to do is look for one of these large vessels like the aorta or the IVC, which is then going to orient you to help you identify the gastric antrum, which is sandwiched right between the liver and the pancreas. Now, these are some of the images that you can potentially see. An empty stomach takes on this, what we describe as a bullseye or a target type of appearance. And this comes from the fact that the gastric wall has multiple alternating layers, but the muscularis layer is the most predominant, it's the thickest, and it has this hypoechoic and anechoic appearance. And so you want to make sure that you identify that thick hypoechoic lining of the gastric wall of the antrum. So that way you can be confident that you're looking at the antrum and not another hollow viscous organ in the vicinity. When the stomach is empty, then this gastric wall becomes quite thickened, and so that's why it takes on this nice thick hypoechoic imaging, and then we'd see sort of this bullseye and an empty bullseye or target appearance in an empty stomach. Early stage solids, you're going to see what looks like a ground glass or frosted glass appearance. And this comes from the fact that when you are swallowing food, you swallow air along with it. And so again, air and ultrasound don't mix. And so we see this hyperechoic air fluid interface, and then we see obliteration of everything deep to the anterior wall of the gastric antrum. While a late stage solid, what's going to happen is that that air is going to move forward or backwards, and ultimately you'll see what appears like a heterogeneous particulate, almost cystic appearance for late stage solids. Clear liquids will appear like all liquids do in ultrasound, anechoic, just like you'd expect to see blood in the heart. So this is what a gastric antrum looks like with liquids. If someone recently swallowed liquids and they swallowed air along with it, or they consumed a carbonated beverage, then you might see these little gas bubbles that take on a starry night appearance. So the question is, what do you do when you get this information? Well, it's relatively simple. If you're scanning the patient, and I want you to know that the patient, when you're scanning them, you can scan them either in a supine or a right lateral decubitus position. But the patient is not considered empty unless they are on the right side and they're empty. And the reason for that is it allows all the fluid or any sort of food or particles that would otherwise lie in the fundus and the body of the stomach now pool within the gastric antrum, and that's going to significantly improve your sensitivity and specificity of this exam. So if you put them onto their right side and you see no content, then you can treat that patient like they're negative for a full stomach. Alternatively, if you, in the supine or the right lateral decubitus position, see obvious solid within the stomach, then you would treat them like a full stomach. What happens if you see clear fluid? Because it's normal for us to have a certain amount of gastric secretions. So this is, again, we encounter that gray area in anesthesia. So how do you proceed? So you can actually quantify how much fluid is within the gastric antrum. And the way that you do that is, again, you're going to put them on the right side, so all the fluid is pooling within the antrum. You're going to measure the gastric antrum at the level of the aorta between peristaltic contractions while it's the most relaxed. And then you're going to use a free trace to actually trace out the cross-sectional area of the antrum, including the gastric wall. And ideally, you do a mean of 3 measurements to minimize error. And based on that cross-sectional area, you can actually use that to determine how much volume is in that patient's stomach based on their age. And so this data is based on endoscopic guided gastric suctioning on large gastric volumes, large BMI, and a wide range of ages from 18 up to 85. And so when you see the cross-sectional area, say that it's 10 centimeters squared on a patient who's in their 20s, then that's about 150 mLs within their gastric antrum. So the data suggests that it's normal for you to have up to 1.5 mLs per kilo, and that's based on your actual body weight and not ideal body weight within your gastric antrum. That's considered a normal amount of gastric secretions. And therefore, if you weigh 100 kilos and you have 140 mLs, then that's considered negative for a full stomach. However, if you weigh 100 kilos and you have 300 mLs, then that's considered positive for a full stomach, and you would treat that patient appropriately. So let's come back to our clinical scenario. And so I, generally speaking, am, before learning how to perform gastric ultrasound, would be one of those people that would say a little bit of milk, that's no big deal. But since I've learned it, I now use this as a way to help guide management. So I went to that patient and I told her, I'm just going to take a quick look at your stomach. And so I asked her to turn onto her right side, and this is what I saw. And so this was a homogeneous hyperechoic fluid collection within her gastric antrum. This is what curdled milk essentially looks like in its sort of late stage. And so I showed this image to the patient, and I said, you're not adequately MPO. It's not safe to go forward. At that point, she admitted to drinking 2 cups of coffee, and that she likes to go pretty heavy on her cream. And so we postponed that case for the appropriate timeline. And the patient actually thanked me. I don't know how many times you've been thanked when you've delayed or canceled the case, but when she saw this image and she realized that she was at risk of having that go into her lungs, then she was grateful that we did the right thing for her that day. When it comes to resources, this is a phenomenal website, gastricultrasound.org. I don't have anything to do with it. It's free, but it does a great job of detailing exactly how to perform and interpret this exam. Again, we have our series in regional anesthesia and pain medicine. One of our articles does cover gastric ultrasound. Again, I like to cross out regional because this really is for everyone. So last thing I'm going to go through very briefly is the FAST exam, which stands for Focused Assessment with Sonography and Trauma. And so here is our clinical scenario. And again, this is another case of mine. I was on call and I was asked to evaluate a patient, 31-year-old female, status post revision hip arthroscopy with severe pain. Now, she has a known history of connective tissue disorder, and she's allergic to all opioids. So the Tylenol and the Toradol that we were giving her, we're not cutting it for her. Her anesthetic was an uneventful spinal, and here are her vital signs. Her pressure's a little soft, heart rate's a little elevated, but she's in pain, and she seems to be doing okay, but she is in a significant amount of pain. And so you go to the bedside, and upon assessment, you realize that her abdomen looks a little bit distended and is tender to palpation. And so I'm going to go into, again, very quickly, the FAST exam. And the FAST exam was initially designed to assess patients following trauma. And it was meant to diagnose or exclude free fluid within either the pericardium or the peritoneum, although it has since evolved to the extended FAST exam, where you actually look at the lungs for things like pneumothorax and also fluid within the pleural cavity. The FAST exam is one of the oldest and most well-studied point-of-care ultrasound exams. This is one of the early publications from 1991 in the Journal of Trauma. And I just want to highlight that using the technology that they had in 1991, the sensitivity, specificity, and accuracy for the FAST exam was 86%, 197% back in 1991. So this was an incredible leap forward for our trauma surgeons and emergency medicine people to be able to use this instead of diagnostic peritoneal lavage to assess which patients needed to go forward for laparotomy in the operating room. Now, when it comes to the modern day clinical applications for the FAST exam, I talked about its role in trauma, like blunt trauma, penetrating trauma. I would argue any patient who's hemodynamically unstable, has unexplained hypotension, you should be looking in the abdomen and pelvis for signs of free fluid, but also suspected ectopic pregnancy, bladder distension, and rupture. And so a lot of anesthesiologists, when I talk to them about the FAST exam, they often ask me, when am I ever going to use this? By the time a trauma patient reaches me, they've been scanned by a trauma surgeon, they've been scanned by 3 emergency medicine residents and 1 attending. There's no point for me ever performing this exam. And to that, I often respond, when it comes to learning these new point-of-care ultrasound skills and applying them in the perioperative setting, you should use your imagination and think about new clinical scenarios that might benefit you. And so one of which is actually hip arthroscopy. And so this was a study that we published out of HSS in Anesthesia and Analgesia in 2017. And so when it comes to hip arthroscopy, there is a well-known complication called intra-abdominal fluid extravasation, where fluid actually tracks from the hip joint into the abdomen and pelvis. And in extreme cases, it's actually caused things like abdominal compartment syndrome and death. And so historically, looking at this data in a retrospective manner, the prevalence of intra-abdominal fluid extravasation symptomatically was 0.16%. So we decided to study this in a prospective manner. So we enrolled 100 patients, and what we did was we performed a FAST exam on them prior to surgery. If it was negative, then we enrolled that patient, and then we repeated it after surgery. Almost all of them were negative because these were healthy young patients. And what we found was that 16 out of those 100 patients actually had fluid extravasate from the hip joint into the abdomen. So this was a 100-fold increase in terms of what we were expecting to see. And more importantly, these patients actually had increased pain scores and had a worse post-op experience. So these are just some images from our study. And we have a young woman here. This is her prior to her hip arthroscopy. This is a pelvic view in longitudinal and transverse. And afterwards, you can see that she now has free fluid surrounding her uterus in the pouch of Douglas and the vesiculo-uterine pouch, again in the transverse and longitudinal view. This is another young woman. This is her scan before surgery, and after we can see clearly free fluid that is tracking down Morrison's pouch in the right upper quadrant. And I can tell you that these patients, they did have significantly more pain post-op. And so this is what we saw, was that their change in pain score from baseline was significantly higher if they had intra-abdominal fluid extravasation, and that persisted throughout their PACU stay. And they also had a trend towards taking more opioids and a little bit of a trend towards more nausea. So let's get back to our clinical scenario. And so upon seeing this patient with their distended abdomen, I thought I knew what was going on, this was most likely intra-abdominal fluid extravasation. So I took whatever the probe that I had available to me. At the time, it was the small curved probe, although generally they recommend the abdominal or phased array probe. But what you can see here is that she had a significant amount of fluid in her left upper quadrant. This is probably several liters of fluid within the left upper quadrant in the surrounding the spleen. We can see a significant amount of fluid tracking down from her peritoneum into her pelvis. And this is her right upper quadrant. You can see fluid tracking into Morrison's pouch. And so what we did with this patient was, one, we placed a bladder catheter because she had, as you can see, a very dilated bladder. And then we gave her some Lasix to help mobilize that fluid, ultimately turned her on her side, did a quadratus lumborum block to help with the pain as well, and admitted her, kept her. She did fine, went home the next day. But at least we knew exactly what was going on, why she was having so much pain, and what to do about it as a result of our point-of-care ultrasound exam. Again, just wanted to highlight as a resource, this is our most recent publication, which also goes over the FAST exam, but again, talking about it in the perioperative perspective for the anesthesiologist. So in conclusion, hopefully what I've been able to demonstrate today is that point-of-care ultrasound is a very helpful clinical tool for us as anesthesiologists in the perioperative setting. It's fast and mobile. It's becoming increasingly so. As I showed earlier, there are these handheld devices that are making it so that you can walk bedside to bedside now with ultrasound to be able to evaluate these patients. It's not invasive. It gives you this incredibly important visual real-time information that you can use to answer simple but potentially life-saving clinical questions. And these skills in particular, although I would say all point-of-care ultrasound skills compared to some of other more advanced techniques, are relatively easy to learn and therefore will become more commonplace amongst anesthesiologists. The question is, at what point might this become the standard of care? I think we're a ways away from that. But I think that there is a future where there may be an expectation where we would use point-of-care ultrasound as a means to augment our physical exam and answer any sort of clinical question that's relevant to that hemodynamically unstable or acute patient. And I hope that someday we'll be walking with these things hanging around our necks instead of stethoscopes. So again, just wanted to highlight this series. Happy to email any articles to anyone who's interested. And this is we have lung ultrasound. I went over that. We have one on focused cardiac ultrasound as well, gastric, and the FAST exam.
Thank you so much.